Hello everyone, my name is Amjad Hammour. I'm going to present a little talk about Glucagonoma, a rare but interesting topic, so let's start. Glucagonoma was first described in 1942 by Beckers when he discovered syndrome with diarrhea, was a triad of diarrhea, diabetes, and skin lesions. In 1966, Big Vern and his colleague found a relation between this syndrome and metastatic tumor of pancreatic alpha islet cells. So, what is glucagonoma? Glucagonoma is a neuroendocrine tumor of pancreatic alpha islet cells that secrete glucagon, and most of the tumor of glucagonoma are solitary, and 10% are related to multiple endocrine neoplasia type 1. Male and female have equal incidence. Usually, it is presented in the fifth to sixth decade of life. What is the clinical manifestation of glucagonoma? Glucagonoma usually consists of weight loss in 90% of the patients, a skin lesion called necrolytic migratory edema with mucosal abnormalities, including stomatitis, cheilitis, and cholecystitis, and diabetes in 80% of the patients. Diarrhea also occurs in 30% of the patients. That is due to increased glucagon and gastrin and vasointestinal peptide. And we don't forget the neuropsychiatric manifestation of the disease. That is included depression, dementia, psychosis, agitation, hyperreflexia, ataxia, paranoid delusion, and muscle weakness. Also, deep vein thrombosis found in 50% of the patients. So, we found also there is, because of the high catabolic state of glucagon, we found most of the patients have a poor nutritional status with low zinc and amino acid levels. So I'm going to speak a little bit about the skin manifestation of glucagonoma, leukolytic migratory edema. It is a pruritic and painful erythematous papules, plaques that enlarge and coalesce into bullous lesions, have a wide distribution mainly in the perigenital extremities and in perioral area, with mucosal involvement that included angular cheilitis, glossitis, stomatitis, or blepharitis. Hair loss and nail dystrophy occur in some of the patients. Here are the picture of the lesions, as you can see. What investigation need to confirm the diagnosis? Investigation, usually we do fasting plasma glucagon level. Most glucagon level be greater than 500. Full blood count for microcytic anemia to look for microcytic anemia. We check for amino acid levels, and we do skin biopsy to confirm the lesion. And also in patient with men type 1 syndrome, we do serum level of parathyroid hormone, gastrin, insulin, and pancreatic polypeptide, and serotonin and vasoactive intestinal polypeptide, prolactin, and ACTH level as its relation with the tumor. Also, we don't forget the imaging that we needed for diagnosis and localizing and detection of any metastasis of the tumor, and also used for staging of the disease. The image includes CT scan, and MRI, and somatostatin receptor scintigraphy, SRS, functional PET imaging that detect small and metastatic lesions. Good in prognosis. Here are some of the image. As you can see, as pointed by the arrows, that the tumor localization there. Here are the different sections is showing the tumor, the arrows there. What is the management of glucagonoma? Usually, management of glucagonoma included general measure like nutritional support, including zinc and amino acid, and surgical is the curative management, especially in early stage of the disease. And somatostatin analogs like octreotide, lenalidomide that antagonize the action of glucagon and decrease the disease progression. And for the skin lesion, necrolytic migratory erythema, use of antibiotic, zinc replacement, and steroid have great effect. We don't forget to give prophylactic anticoagulation therapy before the surgery because of the risk of deviant thrombosis. And in metastatic symptomatic unoperable liver metastasis, we do hepatic arterial immobilization with or without selective hepatic artery infusion of chemotherapy in the palliative patients. Also, there is a rule for radiofrequency ablation to smaller lesion, usually used for post-surgery, adjuvant therapy post-surgery, and in metastatic disease. In advanced disease and palliative patient, combination chemotherapy with streptozocin, 5-fluorouracil, or temozolomide are used, and we don't forget the role of molecular targeting agents such as sunitinib, a tyrosine kinase inhibitors, and everolimus, and mTOR inhibitors. Some benefit of peptide receptor radionuclide therapy that it is used in other neuroendocrine tumor and it shows some benefit in management of glucagonoma. Thank you for your listening, and if you have any question, don't forget to leave a comment, and thank you so much and goodbye.